Bonjour, merci. I hope you do enjoy it. However, being the last to go before our panel discussion, I understand if you're a little sleepy, perhaps drink up that coffee, maybe stand up and sit down a few times. I see my job as both giving you coverage of what's been happening in terms of PrEP at IAS, but also beyond, but also a pretty big task of keeping you awake and engaged at this late hour. To the translators, when I get excited about something, I talk fast. So please wave. I will be looking for you. Alors, merci beaucoup. Okay, great. So in talking about PrEP implementation, I want to cover a few main pieces together. One is that, I want to at least share a little bit on why my perspective is, yay, we're talking about implementation finally. Also want to talk about components of effective implementation, particularly by way of highlights of what was presented at AIDS 2018, but I'll also draw from the literature as well as presentations like from R4P that happened after that. I will rapid speed go through implementation models. You all will have access to these PDFs of these slides, and that is really just to give you some meat to chew upon rather than really dominate the presentation talking about it. And then some key messages. And you and I are going to get through 45 slides together in 20 minutes. You ready? Alors, on va. Okay, so the other thing I did want to share with you in full transparency, if you look at the number of times PrEP was covered at IAS or at AIDS 2018, there were fully 68 sessions that were focused in some way or another on PrEP and 200 separate abstracts. So I am being very selective about what I'm presenting, and I would be happy to talk in informal discussion or afterwards about the pieces that we miss, because we will miss some pieces. I wanted to start by sharing you a little bit of the history of PrEP, and this is a slide by Rachel Bagley. And what I want to emphasize is that a whole lot has been happening for a very long time. And even though we're focusing on implementation, which is the question and the issue in 2018, right, it came from a long history of largely in what many would call a lack of uptake, a lack of aha as it got out of the gate. And so many have called that the PrEP revolution that didn't happen. And there were lots of reasons for that. My own experience with PrEP began right around here in 2008 when I was brought on to the IPREX study as a social behavioral scientist to try to help them to understand why people were not using product. And I've been able to be engaged and work with amazing visionaries, advocates, and communities since then. So I'm really happy to have the chance to share some of my insights and experiences. So why did we have this failure to launch, right, with PrEP? I can tell you that despite the 2012 FDA approval, which was excellent, there were major concerns in the scientific community about efficacy, about adherence, about acceptability, about feasibility. And these were not unfounded, right? I mean, if you look, and I know you can't read this small, but trust me that these lower bars here are showing even negative efficacy in some cases. So when you looked across all the different trials, you had some that did very well and appeared to be very effective. But then you had others that were really causing a lot of pause and question about what is this PrEP and will it actually work? Do people want it? Will women use it? Nobody likes taking pills, all sorts of conjectures that followed. And that was largely because once people started mapping on rates of adherence to efficacy, you start to see this pretty linear association that obviously for PrEP to work, you need to actually take it. And we can talk a little later about what that means, whether you're talking about rectal exposure or vaginal exposure. But by and large, you need to take it, and people weren't. And in light of that, you have to also recognize that Gilead, the developer of the drug, assured the FDA that they would not do advertising. So there was no advertising around PrEP, which was pretty much unheard of when it comes to a pharmaceutical drug hitting the market. We had very conservative and cautious guidelines. Some of our own language stigmatized PrEP users. We said, oh, PrEP is effective for high-risk men, not at high risk, but high-risk men as a personality characteristic. And there was considerable pushback from different parts of the community as well, and providers, about what's going to happen with risk compensation. Are people who are currently condom users just going to throw them to the wind and not do that? And then also, what might we see by way of resistance, right? So is it possible that we're going to exhaust this medication as a viable choice if someone does get infected in the context of this lower pressure that you would get from PrEP? And I'm really happy to report, and especially at AIDS 2018 and conferences that have happened in the last year or so, this picture has dramatically shifted. So what we see now is that there continues to be evidence, study after study, project after project, that is showing that not only is PrEP use effective, it is actually has effectiveness. And it was Jared Bateman's presentation at AIDS 2018 that really highlighted this, that yeah, these efficacy in trials may have been low, but if you give it to people as an open label, hey, this drug actually works drug, there tends to be higher effectiveness, which is how is it actually used. And this was crazy because we never had this in randomized controlled trials of ART drugs, right? Usually, if you're super adherent, it happens in the context of a randomized controlled trial, not in the context of not having any of the supports of a randomized controlled trial. So both my own work and work of others have really unpacked this. And the bottom line, or the piece that I'd like to convey, is that asking someone to take a study drug regularly, that we don't know if it works or not, we don't know if you're getting it or not, and by the way, let me know if it makes you sick, because we're also concerned about safety, that's a pretty hard sell, right? And so when we ask people to take PrEP, we still have some of those components people worry about, but the ask is really quite dramatically different, and we see that people react to it differently. I want to also highlight Patrick Sullivan's work. Now, this is observational, but he was looking at how many new infections relative to PrEP uptake in different states and regions. And while this is observational, what he reported was that you kind of see this very nice correlation between the more people taking PrEP, the lower the rates of HIV infection were. So as we get more of this kind of data, and we all know it's not as pristine and precise as randomized controlled trials, but this is the kind of data that we're going to be looking for and looking at, and increasingly it's in favor of PrEP having effectiveness. Just a note really quickly, we are not seeing the resistance that people were particularly scared of. The handful of resistance cases are typically because people were prescribed PrEP when they were acutely HIV infected. And so that discovery has led to more provider guidance in terms of how do you detect acute HIV infection. The rates of STIs have been going up with or without PrEP, and so that's something that really needs to be unpacked further. The other thing to consider is that for people who are receiving PrEP, they are going through regular STI testing. And so we might just see these higher numbers of STIs because we're getting better at diagnosing them. Many have argued that if you're coming from a place where there's a lot of STIs, PrEP is actually really well positioned to not only treat them, but get people protected so that they're not moving on to HIV. So we have momentum in the scientific community, and we have momentum in some other communities as well. But the UNAID targets of reaching 3 million people with PrEP by 2020, we are nowhere near being on track for that. And so what I wanted to do was to talk to you about some of the findings and more provocative ideas behind PrEP implementation. So I'm not going to give you a whole lot of data. We're going to talk more about the ideas and the considerations from a social behavioral implementation perspective. And I would argue that really if we want to think about PrEP implementation, you need to attend to access, uptake, adherence, and continuity. And that really ultimately is the success score that you would want to have. And what I want to convey is that all of these things are interrelated. And that's where I think everyone here that was saying that their areas are just starting to think about rolling out PrEP, or they're just rolling out PrEP, this is perfect timing because you need to think carefully about how it is that you provide access, because that affects who's going to take it up. And that's going to affect adherence. And what kind of services do you offer? So all of these things, and I believe the speaker before me was talking about getting a comprehensive plan together, these are all really important points. Because when you don't pay attention to it, you end up paying for decisions that you made having unintended negative consequences for future uptake. So quickly, I wanted to just talk quickly about each. So here we're just noting that all components create a context, and you need to be thinking about all of them at the same time. And so when we think about access, I'm not talking about access like where do I get it in my community. I'm talking about countries actually having it to provide. And I'm not going to spend a lot of time on this except for to direct your attention to a number of different resources that are available out there to try to help people, community-based organizations, groups to approach their ministries and to try to figure out ways to tip that hand in the direction of getting PrEP into their communities. So policies, plans, budgets, supply chain management, those are all critical. And access is getting better, right? We know this. It's a slow process, but we know that at least from AVAC's presentation in Madrid, people are using PrEP in at least 68 different countries. And we know from other data that's already been shared today that there's varying levels of uptake in different countries. And some have really have national rollout, so they're in it. It's accessible. All of them in gray really don't. And so when you think about things like migration, when you think about people being mobile, when you think about these kinds of things, you really want everybody on board. So we have a long way to go with this. Available as part of ministry guidelines. This was published in January. I know this has changed a little bit, but at least 10. And that's important because that now becomes part of the formulary and becomes more affordable. In terms of Latin American and Caribbean, as you know, and as people have already discussed, we have a full spread from full on board to national kind of rollout to really local and predominantly pilot kind of demonstration project funded. So what I want to say about access is that it's a work in progress, right? And I do really appreciate that there's now, I think, a lot of political will behind calling attention to this. And here you can see UNAIDS really calling for bold strategies to really bolster up prevention services. They have to be brought to scale. And I know we're challenged with bringing treatment to scale, but we're really in this somewhat, at times, feeling impossible condition of having to do both. But in this area, we've often accomplished the impossible. So that's one thing to pay attention to. The other thing I just wanted to note is that, remember I was saying that everything's kind of interrelated? Is that we need to be cautious about what kind of programmatic restrictions we put on rolling out PrEP. And I was happy to hear a few presenters talking about if someone asks for it, we will figure it out and we will get it to them. When we really focus in on the most at-risk populations, they also happen to be the most stigmatized populations in our community. So if we put PrEP as only for sex workers, as only for MSM, we are really pushing them out the circle. We're taking a group that's already stigmatized and creating higher amounts of stigmatization because it's an in-group, out-group phenomenon. The other thing that you'll experience, which we did and are in the US, is that we really advertise PrEP so much as an MSM specific drug that when it came time for women, oh my gosh, where's the women? We have had a really hard time changing the perception of PrEP as being just for MSM. And that was a result of the way that we marketed it, the way that we made it accessible. So always thinking about, yes, we have key populations, but thinking 3, 4, 5 years ahead of that, are we going to create a problem for ourselves? Also provider-driven. I just want to note that when we put providers completely in the steering wheel of like, okay, only providers can say whether or not you're eligible, we need to be really cautious about that because there's a pretty robust literature of biases among providers. And why do you need that? Just use condoms and you're just being promiscuous. I can't give you that. You're an 18-year-old girl. So we need to really think about if it's the provider's job to do this assessment and make this really pretty influential decision, we need to be debiasing. We need to be training on cultural humility. We need to be doing a lot more at that level to help to make those decisions sound. So access is a necessary but insufficient condition, and that's a real bummer because you spend so much time and effort getting access to your ministries or to your regions, and then you realize that there's this whole other hill that comes up after that. And here is Al Liu's PrEP cascade, and there's a lot of different PrEP cascades out there. There's the double-sided cascade, there's many different kinds of cascades. But essentially, this really maps on that from the patient or the PrEP user perspective, there's several steps that need to happen before you're even thinking about initiating PrEP. And then for the provider, there's several steps that need to happen. So when we think about kind of rolling out, we need to think about the multiple components that really go in. And what I want to focus on in terms of uptake is, I want to talk a little bit about uptake, but then also talk about where does awareness fit in there? Where do the attributions or the way people feel and think about PrEP get in there? And what's the offer? So let me just start with really noting, I think, what we're all aware of, that uptake of PrEP is up dramatically. Now, I'd be really excited about it, but the bar was really, really low. So I'm somewhat excited about it, but we know that it's up about 200% with MSM in Thailand. PEPFAR reported at AIDS 2018 up over 1,000%, and this is just going to keep going up. In Madrid, there was a presentation by Laura Fitch that I thought was really great, summarizing data from AVAC. And in her work, or in their work, I should say, there were 80 implementation studies going on, 31 in Africa. Global guidance was available at 2, so with WHO. And then also 28 national guidelines had been issued for PrEP. And then we had over 309,000 initiators and 44 regulatory approvals. If you compare that to 5 years ago, that is a dramatic increase in PrEP getting out the door. Now, what do we know about that is that almost all of them, or way over half of them, are actually in North America, right? So it doesn't mean that it's spread equally. The other thing in terms of remaining challenges is that we still need to reach key populations. So some of the work that was presented at IAS is saying that adolescents represent maybe like 1% of the PrEP prescribing in the US, for example, and adolescent and particularly young minority MSM are those at highest risk. Young women, high risk. Transgendered people, high risk. So we're not reaching necessarily the people that we need to reach. And the thing that we say in the States is that oftentimes it's more the wealthier white MSM that are accessing it, and it's the other groups that are really suffering behind. So let's talk a little bit about awareness. So we know awareness is important. We talked about education just a moment ago. Really awareness I would think about in terms of, have you ever heard of PrEP and do you know that it's available? And based on the conference data, certainly it's increasing in some areas that have had long time or longer time exposure to PrEP and PrEP information. But there's also the reports from Pintier and then others actually that suggest that low awareness really does persist, even in countries that have some pretty big demonstration projects going. One of the things I just wanted to shout out to a little bit is that there is a ton of information online. There's education brochures, there's facts brochures, there's all sorts of things. The video that we made is located on whatisprep.org. And that's a 6-minute video that talks factually about PrEP. It's not trying to get people to use it. It's just trying to disseminate information about it. And it's been translated in a few languages now. But we were very surprised at how used that particular website is. Right. Okay. So let's get to the big one. And that's just to say providers. All right. So I'm digressing too much. I want to talk about the attributions and the offer, and if that's all I get through, I'll be happy. So attributions is what someone knows or suspects about PrEP. How does someone feel about PrEP? And that is different than educating someone about PrEP's availability. So what do we hear? We know that when people drop off from PrEP or don't want PrEP, they're worried about sterility. Oh, it causes impotence. It's only for promiscuous people. Social harm, side effects, only for sex workers or MSM. It doesn't really work. Stigma, negative health impact, and then also cost as a main component. But I want us to remain aware that we create, and sometimes through our media and dissemination of inaccurate truths, we create those kinds of misbeliefs. But ultimately, we're going to be charged with having to tackle those and to create really positive sentiment towards PrEP. And WHO has a great toolkit for that. A lot of the work that I've been involved with is more drums and drama and community theater as a way to get the word out into the community. Peer mentoring, certainly campaigns. And then there was great work that was presented at AIDS 2018 that I'll leave you with. It'll be in the slides, but they came up with a great strategy for community-based demand creation in Eswatini. So the offer really comes down to the what and the where. What are you offering? What are you offering people when you offer PrEP? And often we roll this out as very medical, it's risk-framed, and it's single service. And decision-making is actually based on return on investment, cost benefit, and value proposition. And here's what I mean by cost benefit, right? So here's in one presentation, when I informed my husband, he refused and told me that he should not find me using it. So I started taking the drug in secrecy. When he came to know about it, when he saw that bottle, he beat me to the extent of destroying my nose. So this is not medical. That is not about your HIV risk, and yet it is a serious thing to think about when you're thinking about PrEP. I would argue that there's lots of things. Here's one presentation that unpacks a decision-making model around PrEP. So there are lots of things to think about when you're considering PrEP. In our own work, we use a social ecological model, even though we also work with the individual, but it's nested within these larger components. I just want to remind people that we still have declines. So even in the case of access, we've got 78% of people that declined in that particular study that was also at AIDS 2018. One of the reasons they declined is that perceived low HIV risk. I want to touch on Sarit Galub's work because she's told us and taught us a lot about our current conceptualizations of risk. So when I say, are you at risk for HIV, it really continues to kind of stigmatize. It's not the way in which we think. I don't think that when I go have sex that I'm going to have risk now. So it's not well matched to how people think about these things. So what her suggestions would be is certainly to ask about desires, reduce anxiety. Do you want to take control of your sexual health? Do you want to increase sexual satisfaction and intimacy, stay safe and healthy, and have a better future? And those are better words to try to engage people in sexual health promotion. In our own work with cognitive interviewing, they clearly said, don't ask me about my risk for HIV, ask me about how safe I am, and do I want to top it off if I'm not completely at the top? And avoiding single service. So for single service, what I'm talking about is I'm just going to have one PrEP clinic, right? Or that's going to be what I do is provide PrEP. The problem with that is that it doesn't really meet a comprehensive needs, right? And so one of the things that we see is that if you can do this within family planning clinics, inter-by community, you can do at-home PrEP even in some cases, in community peer delivery, context of multiple health services, people will be more engaged and more likely, I would argue, to be retained. So adherence is better. I didn't get a chance to talk about adherence interventions and wasn't really planning on it, but I'd be happy to talk to people about it. But comprehensive sexual health counseling is really what I would say is the way to go. And we know that since there's a lot of drop-off as people start PrEP, they just kind of plop right off. My retort is, well, why would they stay? Because if all you're doing is offering PrEP and I'm kind of done with PrEP, I have no reason to come back to you. But if you give me other services like Watch My Sexual Health or preventative care, that kind of thing, I may very well be engaged in long-term conversations with you. So really, things to think about. I am not going through these. These are just for you to have. I want you to know that there are a ton of implementation models out there that can help you with your plan. But I do want to say we are all familiar with Know Your Epidemic, right? Know Your Epidemic. It's how we do our planning. I would argue, from my perspective, when you start talking about implementation, you need to know your community. Because there's a lot of work that suggests that your community has different kinds of relationships with PrEP. And whether you're in distrust or uncertainty or you're aligned with it or have like a mutual championship approach, all of these things exist and we need to be able to leverage them. So broad messages, road's been long. I want to highlight every effort matters. There is no one effort that doesn't matter, so don't feel like going to talk to a ministry or going to see a CBO would not be helpful. It will. And above all, support and respect the dignity of those that we serve. These are all the things we did not talk about, which I would be happy to talk about with you at your convenience, and I'm looking forward to insights and discussions, and I'm 4 minutes over. Okay.